Ashu, can you unmute your mic, please? Yes. So the next speaker is Dr. Ashutosh Yadav. He is Associate Professor of Neurology and Neurosurgery, Director, Comprehensive Stroke Center, Director, Vascular Neurology Fellowship, and the Co-Principal Investigator, StrokeNet, Director of StrokeNet Fellowship Program in Paro Neurological Institute. And his talk is about the role of endovascular treatment in cerebral venous disorder. So the mic is yours, Dr. Asher.
Hello, everyone, and very honored to be giving a talk in your conference. Enjoying the talk so far, and I think that hopefully we can see many of you in person later this year. So I'm going to talk about endovascular therapy for venous sinus thrombosis, which is an area that is still less worked out in terms of the evidence, and so a large part of my talk is going to focus on one of the randomized controlled trial that addresses this topic. So that's going to be the major focus of my talk. And I'm going to give a little bit of a background here. So cerebral venous sinus thrombosis is a specific type of stroke due to a blockage in one of the major veins or sinuses or in one of the cortical veins. And when a blockage there occurs, the etiologies are quite different from arterial ischemic stroke. And as such, the epidemiology for this condition tends to impact more younger patients, especially women, on estrogen supplementation. And the incidence of this is much, much lower than what we see for arterial ischemic stroke, but that epidemiology is higher in women. So the complicating factor with venous sinus thrombosis is it initiates as a blockage, but the venous hypertension and venous blockage then transmits into hemorrhagic stroke. And so some of the manifestations can be both ischemia, that is venous infarct, as well as hemorrhage. The distribution of venous sinus thrombosis can be quite variable, predominantly involves the superior sagittal sinus, followed by the transverse sinus. This whole system is connected, so the blockages can be in multiple areas. The cortical veins can also be involved, sometimes in isolation, and that can be in 17% of cases. More worrisome is when there's straight sinus or deep drainage involvement. That tends to be less common, but those are the patients that end up having thalamic ischemia and therefore present with obtundation and a comatose state. The American Heart Association does give a pretty soft supporting recommendation for the use of heparin in the case of venous sinus thrombosis. It's class 2A level C evidence, and that's mainly because of the original trials that looked at heparin versus placebo for this population. They were very small trials done in Germany, and not very large trials have been done since then. So the level of evidence is arguably very low, but nonetheless, this is one of those examples where the guidelines seem to be sort of disconnected from what happens in reality, as most patients are being treated with heparin when they present with venous sinus thrombosis, despite this kind of lower class of evidence. Similarly, the class 2B recommendation is being made for venous sinus thromboses undergoing endovascular therapy. So there is some guideline recommending both anticoagulation and thrombectomy for this population, although it's based on very low quality data. Now, when patients have venous sinus thromboses, one of the challenges is that the patients can have quite variability in terms of their outcomes. So despite heparin treatment, which can be adequate for many patients, 20% of patients can have severe disability or even have mortality related to the venous sinus thrombosis. And that variability depends really on where the clot is and the extension of the venous clot. And depending on the location, the patients can have alteration in their mental status. They can be comatose, they can have hemorrhage. And this cartoon diagram here shows you the different distribution of venous infarcts that can occur in the case of a vein of Lebet or lateral vein, cortical vein that becomes thrombosed. You don't get drainage of the sylvian fissure, and those patients can have a temporal venous infarct. So those patients can have focality, aphasia, neglect, even motor weakness. When the deep drainage is involved, you can have bilateral thalamic edema, and those patients can present comatose or as well with focality. And then the patients who have extensive superior sagittal sinus thrombosis, those patients have cortical veins involved, and they can have also quite a bit of sort of deficits based on what exactly the distribution is. So here's some examples of what venous sinus thrombosis can look like. In this case, this is the patient with a superior sagittal sinus thrombosis, which you can appreciate on the angiogram here. So what this diagram is showing is that there's decreased filling of the anterior superior sagittal sinus. Next to this panel is another patient with an MRV. Here you can see that the left transverse sinus drains pretty well, the superior sagittal sinus fills well, and usually the right transverse sinus is the dominant transverse sinus because most of the blood goes directly into the right heart. But in this case, you can see the patient does not fill their right transverse sinus very well. So when you have venous sinus thromboses, you can attempt to manage them with medical therapy, that is heparin and hydration, which is the first-line treatment. But in patients where they have neurological decline, for decades now, people have been attempting to debulk the clot, and the goal is really hard to achieve rapid recanalization, either by giving local lytic, mechanical thrombectomy, or some combination of the two. So you take a catheter in through the neck or through the femoral vein, you go up to the clot interface, and then using the same maneuvers we use for arterial occlusions, we try to aspirate or macerate the clot, use a stentriver to pull it out, or inflate a balloon and drag the clot back. And so in many ways, this is replicating what people do for deep venous sinus thrombosis in the leg for like a DVT. You can really think of venous sinus thrombosis as basically a DVT of the head. And so there is some reason to think that perhaps some of these similar maneuvers may be beneficial to debulk the clot, allowing the anticoagulation to penetrate further into the clot itself. So I'm going to just put this talk in the context of a clinical vignette. So this is a patient that we took care of recently. It's a 25-year-old with a history of celiac disease who presented with confusion and first-time seizure. You can see the head CT shows a little bit of a hypodensity here in the upper right cortical region with perhaps some hyperdensity in that hypodensity, so a little bit of blood products. And this patient, you can see on the CT venogram, has like this empty delta sign, that is, there's no filling in the superior sagittal sinus, so there's a filling defect in that triangle that is the superior sagittal sinus. So we keep that patient in mind as we talk about the 2-ACT study, which is the kind of bulk of this talk. The 2-ACT study was a randomized controlled trial that investigated patients who presented with venous sinus thrombosis, and it looked at patients who were managed medically with standard of care versus endovascular therapy. So the goals of this study were to look at the safety and efficacy of endovascular therapy, especially in severe patients. And the specific question was, does endovascular therapy with guideline-based medical therapy improve the functional outcome of patients with severe cerebral venous sinus thrombosis? This trial was conducted in 3 countries. It was a multi-center, open-label, blinded endpoint, and it was done in Netherlands primarily, as well as China and Portugal. And you can see the enrollment was slow, and this was done over 5 years, and the patients were enrolled basically across those countries. You can see that this was the inclusion criteria. The patients were to undergo intervention as soon as possible, but no later than 24 hours. The strategy for endovascular therapy was left to the discretion of the interventionalist, and it allowed mechanical thrombectomy, which includes the angiojet, as well as stentrivers, balloon angioplasty, microcatheters. Local lytics were allowed, so to have continuous infusion of alteplase urokinase was permitted in the study. And then, of course, you could do a combination of the 2 modalities. So this was what was allowed in the study. In terms of the heparin management, patients were got heparin either during the procedure and continued afterwards, or they had the heparin stopped during the procedure. And this is kind of a practice variation. Some procedurists like to hold the heparin during the mechanical thrombectomy portion. The control arm got heparin in a therapeutic dose, and this was either unfractionated or low molecular weight heparin, such as Lovenox. And then after the acute phase, patients would then receive some kind of vitamin K antagonist for 3 months. And if there was a provoking factor or transient risk factor, such as post-operative, or is there some medication like estrogen, then those patients that had a provoking factor were anticoagulated for 3 months. The ones who were unprovoked would be longer for 6 to 12 months. And the duration of anticoagulation is really up to the local investigator. So there's some practice variation on that aspect of management. Patients were enrolled if they were above 18 years of age. And the severe definition here would really be based on one of these high risk factors, that is mental status, which is a little bit vague, but drowsiness or some alteration in mental status, comatose, so that is GCS less than 9, hemorrhage, or involvement of the deep system. And the usual exclusion criteria that we think about, such as pregnancy, patients with low platelets, patients who could not be safely anticoagulated, such as major recent surgeries, patients that would require open surgical intervention, that is signs of impending herniation, patients that may have independent conditions. For example, a lot of these patients may have cancer as part of the reason why they're hypercoagulable and have a venous clot. So that was an exclusion criteria. And then the clot had to be felt to be less than 10 days of age. So they didn't want the clot sitting there for too long. The patients were, it was open label blinded endpoints, so that the providers knew the treatment the patient got, but the investigators that were assessing the patient at the different clinical endpoints were blinded. And so this was a way to ensure that the assessors did not know what treatment the patients received. The primary endpoint here was a modified Rankin of 0 to 1 at 12 months. And there was additional multiple secondary endpoints, including MRS 0 to 1 at 6 months, MRS 0 to 2 at 6 and 12 months. Recall, for most of the arterial ischemic trials, we use MRS 0 to 2 at 3 months. So just as a comparison. And then the MRS was looked at both dichotomized, 0 to 1 or 0 to 2, or as a continuous variable. Recanalization, and we'll talk about the scoring for that, as well as any additional surgical interventions that were performed relative to the venous sinus thrombosis. The safety endpoints included hemorrhagic complications, any kind of symptomatic hemorrhage within 1 week of randomization, and then any mortality at 6 or 12 months. Recanalization was determined for each sinus. Complete recanalization was defined as uninterrupted flow through the venous system. Partial recanalization, which is there was flow with some interruptions, and then no recanalization, that is interrupted blood flow. And this was assessed by MR venogram. So here are some examples of the types of scores that you might have seen in this clinical trial. And we can see that the patients could have complete recanalization, as in this panel A, partial recanalization where there's flow, but there's some interruption, and then absent recanalization. So the trial was basically powered to look for a 20% difference in the MRS 0 to 1. So that may be a little bit ambitious. So that may be something that not everyone would agree with. And it was powered for a sample size of 164 patients. There were 2 interim analyses performed at 1/3 and a 2/3 enrollment, and we'll see that the trial did not complete enrollment due to that interim analysis. And the stopping rule for fatality was basically if it was felt that the likelihood of achieving that primary endpoint would be less than 20%, then the trial would be terminated early. And this was done at 1/3 and 2/3 of the study population being assessed by the DSMB. The subgroup analysis was based on presence or absence of ICH, presence or absence of comatose state, and presence or absence of deep sinus involvement. And the scores that were used for the total number of sinuses were basically divided based on the different locations where we see venous sinus thrombosis. So a point was given for superior sagittal sinus, straight sinus, left transverse sinus, right transverse sinus, left sigmoid sinus, right sigmoid sinus, and either jugular vein. And basically, the complete recanalization of the two most common locations, the superior sagittal sinus and straight sinus, were separately adjudicated. The statistical analysis was performed as an intention to treat. So it was basically whichever group you were randomized to. And the first interim analysis was at 55 patients. And at that point, the study was recommended to be terminated based on futility by the DSMB. So the trial actually did pretty well in terms of how trials performed. The 6-month follow-up data was available in 100% of cases, which is pretty fantastic. And then the 12-month for 66 of the patients, or 99%. One thing to keep in mind is that the trial actually was pretty selective in who was enrolled. So you can have some discussion on how applicable these results are for all patients. It was 67 out of 420 patients that were in the trial. So only 16% of patients that presented with venous sinus thromboses were actually put in the study. So this is a very select group. So only 1 out of 8 venous sinus thrombosis patients were enrolled. And during this study period of time, 26 patients did go endovascular therapy outside of the context of the trial. So here's how the enrollment looked. So there were 67 patients that were put in the study, 33 in the endovascular group, the rest in the medical therapy group. And you can see in terms of the intention to treat, most of the patients did get the treatment that they were assigned to. And this is basically a really good retention rate in terms of assessing the primary endpoints. So some things to kind of point out. I mean, this is a pretty small sample size of patients, but there was some baseline discrepancies. So the EVT group was slightly older, 43 years of age versus 38 years of age, and had slightly less women. The median NIH was 12 in both groups, so that was pretty well balanced. And both groups had comparable rates of hemorrhage on presentation. And both groups received heparin about 80% of the time at the time of randomization. So pretty well balanced in that sense. These are the baseline features. One thing to point out is that the endovascular group did have a higher percentage of patients that presented with coma. And so that was 24% of the patients versus 15% of the patients. So that may have tipped the balance a little bit in the favor of the medical therapy group. Both groups had a high percentage of women that were on oral contraceptives. And the superior sagittal sinus was the most commonly involved location. And the deep drainage was involved in 40% of cases. So quite a number of patients that had deep involvement as well. In terms of access, and this is something perhaps for the other interventionalists to comment on, most of these patients were treated via the direct jugular vein access, and then 25% were treated via femoral vein. The remaining one patient was treated by a dual approach. In my own practice, I use a femoral approach, but I think that, as you can see from this study, a lot of people use a jugular approach as well. In terms of the mechanical thrombectomy, they use angiojet device, which, to be honest with you, I've only used once for this indication. Predominantly, I use aspiration catheters, and then stent retrievers were used in a small percentage of the cases. There was chemical thrombolysis with urokinase and alteplase locally, and in 9% of patients, a continuous infusion was used, which, again, I don't do that personally, but I think that many people do consider that approach. In terms of the specifics of the endovascular technique, you can kind of see the breakdown here. We just kind of summarized this in the previous slide. Most providers did continue heparin during the procedure, which I think is reasonable given that you have catheters in the brain and you're dealing with a clot. And as opposed to arterial ischemic stroke, the concerns about hemorrhagic transformation are a little bit less in terms of clinical sequelae. In terms of the results at 12 months, they were pretty even. 22 patients that got endovascular therapy, or about 67% had MRS of 0 to 1, and that was almost exactly the same in the medical therapy group. At the end of 12 months, the number of patients with an MRS of 0 to 2 was 85% versus 82%. So both groups did pretty comparably. This is the sort of grata bars showing you the outcomes as broken down by MRS. And the superior sagittal sinus was more likely to be recanalized at the 6 to 12 month mark based on MRV. So that is intriguing. Again, it didn't really translate into kind of any clinical benefit based on the sort of MRS of MRS 0 to 1, 0 to 2 at 6 months and 12 months. In terms of mortality, there's no significant difference in mortality in the two groups, and there's no statistically significant symptomatic hemorrhage rates in the two groups. And so basically, the safety features were pretty comparable for both endovascular therapy and for the standard of care group. So the trial did show that safety of this approach. Complete recanalization was again seen more often in the superior sagittal sinus in the endovascular therapy group. That's 79% versus 55%. That was statistically significant. And we can discuss whether that has some implications on patient outcome that may be more subtle than the usual MRS outcome. And the recanalization sum score that we talked about earlier was comparable between the two groups. In terms of the other results, they did look at various adverse events that were related to the index diagnosis of venous sinus thrombosis. I should point out that there was 3 perforations during the endovascular therapy group, but that did not have any clinical sequelae. Both groups had decompressive hemicranies and EVT placements. Interestingly, the standard of care group did have a higher percentage of seizures. So arguably, this may have been related to debulking of those sinuses and allowing the cortical veins to drain. Again, what the long-term clinical sequelae are is unclear, but this may point to a more subtle primary endpoint. The perforations, as I mentioned, were in 9% of patients, but they did not lead to symptomatic hemorrhage, so they're pretty self-limited. The perforation of a vein is a lot more forgiving than perforation of an artery. In terms of the MRS of 0 to 1, it did not differ based on the first half or the second half of the study, so this was not related to some sort of learning curve for the procedures that were involved with the study. Interestingly, when you look at the results by the different prognostic variables, it is interesting to see that by chance, the endovascular group had a much higher rate of patients that were comatose compared to the patients that presented with in the medical therapy group. So that may have tipped the balance in favor of the medical therapy group. And as I mentioned, during the trial, they maintained a registry of patients who were treated outside of the trial. And that's important because maybe there's some kind of patient bias or selection bias, and we did not see any difference in the patients that were treated outside the trial versus within the trial. So I think that probably what would be valuable is to have some discussion about the limitations of the 2X study. It is the only randomized controlled trial data we have on this topic. So while it may not show benefit of endovascular therapy, I think there are some important lessons to be gleaned from it. It was a very, very small sample size, and clearly there was some selection bias because only 16% of patients that presented with venous sinus thrombosis were treated during the study or that were enrolled in the study. And then, of course, early recanalization was not part of the endpoints. And this may be relevant because when we think about endovascular therapy for arterial strokes, we're very interested in early recanalization because we think time is brain. The sooner you open the blood vessel, the more likely there is going to be benefit for the patient. For the veins, this is slightly less well understood, but at least in this trial, early recanalization was not assessed. And again, that may be relevant for a more subtle primary endpoint than MRS. So going back to this patient, in my clinical practice, I do tend to offer endovascular therapy for venous occlusions, especially when the patients meet one of the sort of severe criteria. This patient had some blood, had some confusion, and did have a seizure. So this is kind of the system that I typically use. I go femoral with an arterial catheter to take diagnostic angiographic runs, and then through the femoral vein, I go with the Neuron Max, and then I use some kind of aspiration catheter, the largest one that's available. So on this image here, you can see on the native and on the subtracted image that we have a Neuron Max here, basically sitting in the transverse sinus, and then the React catheter is in the superior sagittal sinus, and then we use a microwire microcatheter system to get distal. So this is a patient where I got the aspiration catheter into the clot and did 3 passes of vacuum aspiration. The results for this are sometimes not terribly impressive on the venous runs, and I think even on the arterial runs, we don't see significantly open vessels like we're used to seeing for arterial injections. But you can see that on the MRV, there's much improved recanalization of that superior sagittal sinus. And this patient actually did very well, was discharged on Pradaxa with an MRS of 0. But again, for every one of these patients, we certainly see patients. I did a case last week with a patient with extensive venous sinus thrombosis involving the straight sinus. I was not able to get a good radiographic result, and the patient has really not woken up since the venous thrombectomy. So I think this disease is quite variable, and part of the challenge may be that we don't have all the right tools to open up these vessels. So this is my last slide, and I just wanted to kind of talk about a few things. One is that while many of these patients do very well, it's clear that there's a subset of patients that don't do very well, and that population is what we need to figure out who they are and how do we offer a better treatment. The other issue is that there may be other comorbidities these populations develop, such as seizures, headache disorders, and these primary endpoints may be relevant as well, rather than just MRS. The 2X study did not show benefit of endovascular therapy, and so we have to keep that in mind as we continue to figure out how do we find the role for this treatment. And the future endovascular trials may continue to focus on patient selection. That is, are we picking the right patients? It's a mixed population. The younger patients, it tends to be provoked from dehydration and from estrogen use. Older patients may be a population that has cancer, malignancy. There may be something that's causing them to become hypercoagulable. So it's a very, very mixed population. The relevant clinical endpoints, I think, still need to be ironed out. We don't really know if MRS makes sense. Maybe we should be looking at seizure frequency, headache frequency, other primary endpoints that may be relevant to the patient's quality of life. And then I think one of the challenges that I personally think this field still struggles with is we're using arterial tools to solve a venous problem. And these tools may not be the right ones. And I in many ways, it's the same issue when we talk about going transradial for neurointerventions. We're using femoral tools to solve problems that are different, going via radial approach. So I think part of what's lacking is good tools for venous thrombectomy for the central nervous system. I've always been intrigued by this system. This is the flow retriever system that people use for aspiration for PEs and for DVTs. And I think that we need to start thinking about better tools for the central nervous system, that the sinuses are pretty large. Obviously, we worry about being safe and causing perforations and subdurals going in the veins, but I do think that we need to think about a much better approach as to how do we recanalize the vessels in the veins, and how do we measure success. One of the things we do in the arterial side is we give a recanalization score immediately after recanalization. I think that's been something we struggle with on the venous side. So this is my last slide, and kind of interested to hear what other interventionalists are doing for venous sinus thromboses, and happy to take questions. Thank you.
Thank you so much, Ashu, for this very nice presentation and very comprehensive also for covering such a tender topic. And I think I have one comment, and then we can go to the to couple of questions from the attendees. I think I agree with you, and I echo the last message that you showed in the last slide about the design of such a trial. I think one of the ways to kill a practice is to design unplanned randomized controlled trial, and you are expecting to have some consensus from this randomized controlled trial, and we have a history in such a situation like in Sempress studies and others. And translating clot, for example, burden in the venous system is totally different from that principle in the arterial territory. And we see sometimes a huge burden of clot with minimal presentation in the venous system, and vice versa. We see sometimes a very tiny clot with a huge presentation. And even sometimes we can recanalize the full a clot in the venous system without a good outcome, and we can do the vice versa in a very small clot with a tremendous outcome. And I think, do you think that the examination of the venous collaterals, the venous pattern of drainage, and sometimes we can put more concern about the venous system as a drainage system for the CSF and the intracranial pressure of the brain, not just a vascular territory of the vessels, of the CNS vessels, is somewhat that has been considered, that should be considered when we examine such a spectrum of disease. It is not one disease, I think it's a spectrum of disease.
كده ال 4G شغال عشان لما اقفل وافتح الراوتر يا باشا. دي علامه ال 4G مثلا.
الو
دي علامه ال 4G.
اسماعيل.
ايوه.
Can you mute your mic, please? Can you mute your mic, please? Okay, thank you. So Ashu?
Yeah, I heard your question. I think that, you know, the venous system is obviously much more variable than the arterial system. And so the heterogeneity you describe in how patients present is key to this disease. I mean, I think people probably have silent venous sinus thromboses that we don't know about, and then they present later on with a dural AV fistula or some other sequelae. Or sometimes we do an angiogram when we see an occluded sinus, but we weren't expecting it. So I think that you're absolutely right. On one hand, the veins are more forgiving, and if you progressively occlude a vein or you occlude a vein and you have very good alternative venous drainage, it definitely makes sense that, you know, why some patients can have extensive venous sinus thrombosis burden and not have a lot of problems. They've developed really impressive cortical drainage, and then other patients become very altered. And I think partly why some of the ones that become altered is because it's not very localizing, because you can have a clot, but then if you occlude a draining vein that relies on that, like if you occlude Labé because transverse sinus is occluded, those patients can get in a lot of trouble. But you can have an extensive clot somewhere else and be okay. So I absolutely agree with you. And the venous system itself, we kind of lump together, but, you know, deep is very different from superior sagittal sinus, very different from the, you know, cavernous sinuses. So I think that all this variability is what makes this hard for us to try to lump together, and then to try to draw conclusions from a trial with 67 patients doesn't make a lot of sense. You know, it's a very ambitious way to kind of understand this problem. So, you know, intuitively, it makes sense that if we debulk these clots, we sort of reduce the amount of time the patients may need to be anticoagulated or how long they're in the ICU. And using MRS may not make sense for us as a clinical endpoint. And generally, I think it's a very safe procedure, which is why my threshold to offer it is pretty low. But, you know, I think that, of course, with astrocells, are we making a difference? And that's the area where we struggle, because you can always show a good example, but it doesn't mean, and the other problem is you don't know if the patient necessarily needed it. Like the example I showed, maybe the patient would have done fine without the thrombectomy. So it's a tough area. I mean, I have to say, in my clinical practice, it's rare disease, but I do tend to offer it if they have one of these severe symptoms. But I have some partners, or I've seen other people even take patients sooner than that. If you have a young person, just headache, and they have a superior sagittal sinus, they'll argue, let's just open it now before this becomes one of the severe patients. So that's the other argument, is maybe by waiting for the patient to get severe, we're waiting too long to help the patient. So it's like treating a large core patient. Maybe the treatment effect is not as robust. Maybe we should do it sooner, and then we can really save the ones who are going to get in trouble. So I agree. I mean, this is a very difficult condition also because the etiologies are quite different. Why young people get it versus older people is very, very different. So, I mean, it's a kind of interesting work in progress. And I think the biggest opportunity here is better devices, because, I've done these, I mean, we've all done these cases. You take out a ton of clot, it looks good, and then you do the run and it doesn't look any different. There's still a lot more to go. And so that's where, if you look at these results that people get for peripheral clots, PEs, I mean, they're pulling out tons of clot, and I think that they just have much better tools for this. So if there's anyone in your meeting that's from industry, I think this is an opportunity to consider, is how do we safely take out clot. And I have to be honest, I only just do aspiration. I've seen some people put stents down too to keep the sinus open. I think that's an interesting thought. But then they're on anticoagulation. You got to then put them on dual antiplatelets. Maybe they need a decompression or a EVD. So these are tough cases. But yeah, I'm curious what other people are doing.
So I think to sum up, I think we can mention some criteria that in favor of to be prepared for shifting the patient for intervention, early intervention. For example, a younger patient has a history of a medical problem like protein S, protein C deficiency, or something that increase the coagulopathy of this patient profile. Also, the affection of the deep system of the venous system is another criteria, and also sometimes the rapid progression of the symptoms in a shorter time is another way to include the patient for a more aggressive treatment than wait and see protocol. And similarly, I think also the presence of something that indicating there is a high pressure in the brain is also indicating to move the patient from wait and see protocol to the endovascular treatment. Do you think that this could be a good message for the attendees about this treatment so far?
Yeah, I think that's a great list. I would also add, sometimes there are patients that because of trauma or some other issue, they're high risk for anticoagulation in the short term. And some of the cases that I get referred are patients where they have thrombocytopenia or they have some issue, and people are not, they don't feel comfortable anticoagulating, or they're trying to figure out, can we do it? And so in those cases, I will do the thrombectomy and hydrate till they figure out if the patient is safe for anticoagulation. And keep in mind that the data for anticoagulation is not phenomenal. I mean, we learn all this. I mean, this is what you don't even ask question. As a resident, as a trainee, we teach everyone, if it's a DVT of the head, we have to anticoagulate. But the level of evidence is not very good at all for this. So we're doing it just because it makes sense. It's a logical thing to do. And I think the venous thrombectomy also seems intuitive. It seems like the logical thing to do. But the list you made is very good. And again, if this high risk group, if they have a seizure, if they have a large hemorrhage, I tend to take those patients as well.
Yeah, I think we have two questions from the attendees. One from Dr. Yasser. Can this treatment be applied to children?
Yeah, I mean, I think there's no reason to do something different in kids, and I kind of think of children as almost like 2 or 3 different groups. I mean, less than 10 years of age is different than, a teenager or adolescent. So once they're a teenager, I treat them exactly like adults, even for arterial strokes. I think when they're less than 10 years of age, it gets a little complicated in terms of the tools, but above like 5 to 10 years of age may be still possible to do these maneuvers. But I think you have to take the situation, understand why is this child having clots and figuring out the mechanism. But I don't think that age, either too old or too young, should be any kind of limit for us. But we have to think about why is that patient having an issue.
And the last question.
I think that's it, Osama.
Yes, last question is, do you have any preference regarding the usage of the anti-vitamin K anticoagulant versus NOACs in such?
Yeah, there's a trial in JAMA Neurology where they looked at Pradaxa versus Coumadin, and they showed that Pradaxa is as good as Coumadin. So increasingly, I use DOACs and NOACs in this population because it's just easier for the patients, higher compliance, for all those same reasons we do it. And remember, this is venous, right? So the data for this is much better for NOACs in the venous side than for like AFib or something. So yeah, I think that nowadays it doesn't make sense to use Coumadin if the patient can afford NOAC.
Thank you so much, Dr. Ashu, for this presentation and for this discussion. Dr. Ismail.
Thank you for the whole speakers as well as the whole attendees. We actually spent a nice and informative night about cerebrovascular stroke. I thank you all, and I hope that we can see you soon in Alexandria, maybe next year. Thank you all, and good evening.